everyone to today's Endocrinology Grand Rounds, and we are very happy to have Nathan Liu from the Division of Gastroenterology in the Department of Medicine talk to us about the state of bariatric endoscopy. This is certainly a new field. He will say it's not that new, but it's new for us, and certainly very new in terms of being introduced here in Louisville. And Dr. Liu trained at Emory University, obtaining his undergraduate degree and then medical school at Augusta. He came to UofL, where he did his internal medicine residency and GI fellowship. Later went to Florida to do advanced endoscopy fellowship, where he learned a lot of things. And one of them is this particular procedure. He came back to Louisville, so we are very happy to have him back here. And he has been as assistant professor here for the last 1.5 years or so. He is, director of the endoscopy at Jewish Hospital, third space endoscopy, and then also interventional gastroenterology. So he has quite a few publications and presentations in the field of, mainly in the field of endoscopy and therapeutic endoscopy. So I will have him take over and introduce us to this and, giving us more opportunities to help our patients who need these kinds of procedures. Thank you.
Right. Thank you for having me. So really honored to be here today. So in the field of endoscopy, we have made so many improvements just within the last 10 years. In terms of third space, doing POEM for achalasia, G-POEM for gastroparesis. We're doing interventional endohepatology by doing portal pressure measurements. We're doing endoscopic ultrasound liver biopsies now. We're also doing rendezvous type EUS, ERCP. So it's just so many advancements. And the next field we're kind of looking at is in terms of bariatric endoscopy. And I'm glad to have Lizzie here. I always tell people that in terms of, the field of how bariatrics and GI and surgery fit in, it's not a one-stop shop, meaning it's a continuation, and you really need a team and an effort to help these patients. And there's so many patients out there who need some type of help. And really, if Dr. McClave will tell you that the body is stacked against them, they're fat because they're obese, and they're obese because they're fat, and it's kind of a continuing cycle. So we have to do something other than just promote nutrition and weight loss for them to actually lose weight. So I'm really excited here to kind of talk about that. So just a few things to kind of go over. Our objectives, talk about the prevalence of obesity, talk about the role that endoscopy can have. What is this procedure called ESG, and what is a TOR? So obviously, obesity has a huge economic burden. It's only growing. 2016, you're looking at $261 billion, and I'm sure it's only going up and up and up. In terms of obesity in Kentucky, just based on the 2021 CDC map, us and West Virginia are the only two people in their own category right now with over 40%. So unfortunately, we will probably see these colors darken in the next 10 years, and we're seeing that everywhere it's becoming more on the dark side rather than the yellow and green side. So just a few definitions. Obviously, you guys all know this: class 1 obesity, BMI 30 to 35, class 2 BMI 35 to 40, class 3 BMI of over 40. Now, BMI is a kind of what I say a dirty measurement. It's not really end all be all. It's just a quick way for us to kind of tell. But some people, even with a BMI of 28, they have metabolic issues, and weight loss is helpful for them. So, but BMI is kind of how we're classifying everything. So if we look at all of our different armamentarium for weight loss, number one, always lifestyle interventions, diet, exercise, education, pharmacotherapy. I'm not going to cover that today, but obviously that's a big thing now. Bariatric surgery, laparoscopic sleeves, duodenal switches, Roux-en-Y gastric bypass, adjustable lap bands, I think are kind of falling out of favor. And then now endobariatric, so intragastric balloons, ESG, TOR, and then we're not covering duodenal resurfacing, but this is something I'm hoping we're starting soon. I don't know what's taking so long. I emailed and I've been sending all this stuff. I don't know what's going on, but hopefully we're starting that soon. So I always tell people only 1% of people actually end up undergoing surgery. So there's a lot of people that don't undergo surgery. And my mind is the patient wants surgery, I will be the first person to send them to surgery if they're a surgical candidate, that's what they want. But there are quite a few people that aren't ready to commit to surgery. Maybe they have a lot of comorbidities. Maybe they're trying to have surgery so they can have a transplant of some sort. So there's a lot of patients out there. And so really we want to be able to provide them with the different kind of benefits and treatments out there to help them. So endoscopic bariatrics is just one piece of this puzzle. It's not the entire slice, or the entire pie. So in terms of those procedures, intragastric balloons, sleeves, TOR, duodenal resurfacing, and Aspire. I think Aspire is out. This was basically the peg tube where you could let food out. That's kind of fallen out. I don't think the company's around anymore. So this is my fellow and me. We're at the Apollo course. This is the Orbera balloon. It's a silicone type balloon. We usually fill this with 500 mLs of saline, and then we drop it in the stomach. It's been approved since 2015. It's been around the whole world for the last 20 years. A lot of people are using balloons. Thing about the balloon is it's really temporary. It's only supposed to really last for 6 months. You don't want to put a balloon in somebody that's not going to come back. So this is a very temporary thing. In Boston, they're doing this to like try and lose weight for the summer season. I don't think that's a really appropriate use of it, but it's basically kind of cash pay. We put a balloon in, and then you easily take the balloon out. So it's approved for BMI 30 to 40. It's primarily a bridge and surgical tool. It occupies gastric space, and it basically causes gastroparesis in these patients. And so they feel really full, nauseous, they have bloating, and they don't eat as much. And if you look at the 6 month you're looking at 10 to 12% body weight loss. But if you look at the long-term data, the reason why this is not being used a lot is after 2 years, all that weight basically comes back. So you don't want to use this if they have a large hernia, obviously varices, no. And then if they're on anticoagulation or if they have a history of ulcers in the past. There's been 1 or 2 perforations from this, mainly because the balloon was underfilled, it migrated, or the balloon went up into a hernia sac and got caught and perforated. So adverse events, nausea, vomiting, pain, GERD, perforation was rare. And then there have been some cases of infection in the balloon as well. The new balloons that are silicone, they are really tough. They're so tough that you have to take all the fluid out before you can take this balloon out. So the infection we haven't seen that in the last 5 years. So there's a whole bunch of different models. The main one is the Orbera in the U.S. There's a few where you actually swallow them and then you blow the balloon up, and there's a few that they can self deflate. The Orbera is the main one that we use. That's the one where we endoscopically go in there, we fill the balloon up, and then we endoscopically take it down to make sure it's gone. So the procedure that we're starting to do, hopefully we're getting up and running soon, is endoscopic sleeve gastroplasty, also called ESG. And so what we're doing is we're doing full thickness suturing of the stomach to shorten and reduce the volume. So this is supposed to be a permanent change. It does cause hormonal changes. And the best part is we do not involve the fundus and the antrum. So I'm not touching either of those 2 spots. So by avoiding the fundus, I do not cause issues with accommodation of the stomach. So patients don't typically get as much acid reflux. So I'm going to pull up the video now. That's usually the best way of kind of showing it. Anybody have any questions at all? So we'll go over the data now for it. So all I'm doing is you come in as an outpatient. We put you to general anesthesia. You'll be paralyzed. You'll be completely asleep. Procedure takes about 1 hour to an hour and a half. And we use this device for other things like suturing, perforations, suturing, any type of anastomosis, close as well too. So we use it for a lot of things, but this is something that it was actually designed for. And so that's kind of what we're using it now for. So what's big about this is they get to go home the same day. Typically, we give them a few bags of IV fluids before they go home. They can have some nausea. Usually the first day or two, there is some abdominal pain. The pain is usually from air trapping. It's from folding the stomach, and that usually goes away. And I've been told within the first 72 hours that the stomach actually remodels. And because it's a mucosal serosa to serosa adhesion, that these things are, it's pretty much permanent. Now, sometimes if they overeat, the stomach can kind of loosen, the sutures can loosen as well too, and they can regain weight, but that does happen. We can go back in and tighten it. So differences with the laparoscopic sleeve, there is a lower risk of perforation leak. We leave the fundus intact. We don't configure the stomach into a straight barrel type fashion. There is a decrease in leptin, and we have seen that it prevents compensatory rise in ghrelin, and we don't cut from the outside at all. So it is FDA approved, and this is the large study that came out that when this released, this is when Medicare decided to make this a procedure where they would pay for it. So this was a multi-center trial, and we looked at patients with a BMI of 30 to 40, and they randomized them to either endoscopic sleeve or they did lifestyle modification, and at the 25-week mark they crossed them back over. And if you take a look here, within the first year, the people that had the ESG had a 49.2% excess body weight loss compared to 3.2% lifestyle intervention. The mean body weight loss was 14% for the ESG group and 0.8% for the control group. And then when they crossed them over at 52 weeks, the crossed over group had the same weight loss. So you can see here in this graph, once they had the ESG done, they started losing the same amount of weight here. So there were 3 adverse events. One person had a GI bleed. We're literally putting sutures into the stomach. There was 1 abdominal abscess managed endoscopically, no surgery. And then 1 person did have malnutrition and the ESG was reversed. So they went in there, they used fluoro, and they cut the sutures down, which is not something we recommend doing. In terms of hypertension and diabetes, we noticed that diabetes and hypertension got better. Hyperlipidemia did not get better with this. So most importantly, these patients that had an endoscopic sleeve, no acid reflux came about. And it's because we don't touch the fundus at all. So food goes down, it sits in the fundus, and then it goes in through the sleeve, and then the antrum is still intact. So we don't touch the antrum at all. Now, how high can we go? So they looked at patients in class 3 obesity, and these patients actually had even more weight loss. We're looking at more than 20% weight loss at year 1, 2, and 3. So even if their BMI is above 40, they lose the weight the exact same. Contraindications, we don't want to use this on pregnant women, uncorrectable coagulopathy, large hernias. We don't want to use this if they have a history of having dysplasia in the stomach, in any case where endoscopy is contraindicated. And we typically don't like to do this if they have an eating disorder as well too. So they should have already seen a psychiatrist and had this kind of ruled out. We don't want to do this in cirrhotic patients as well too, diffuse polyposis, known history of gastric cancer, substance abuse. So this is a study looking at how high can we go. And we're looking at patients with BMI 60, 70, above 70, and actually they had the same amount of body weight loss, and they did not have any change in adverse adverse events. So obviously their recommendation was we need more studies, but you can do endoscopic sleeve for patients above 70. Mainly they just need to be able to have general anesthesia. So now we're going to switch gears. We're going to look at TOR. So if you look at Roux-en-Y gastric bypass, there are some complications that can happen. So this picture here is a anastomotic ulcer. This is where there's usually a ischemic issue or they're smoking. They can have bleeding at the site. This is a gastric fistula, meaning you're eating food and rather than it just staying in the pouch and going into the jejunal limb, it's actually going right back into the remnant stomach. And so their bypass is basically compromised. So this is a picture of what a Roux-en-Y gastric bypass kind of looks like. You're going down, you have a pouch, you have a Roux limb, it comes back up, and then you actually still have your remnant stomach intact here. And then the pancreaticobiliary limb comes down, and then what ends up happening is these two meet, and then you have food going down the efferent alimentary limb here. So this is a picture where you can see there's a really large stoma here. This is probably the blind pouch, and then this is where the food's supposed to go down. But this is just wide open here. So if you look at Roux-en-Y gastric bypass, there are some complications. They're divided into intraoperative, early, and post-op. So you can have bowel obstructions, wound complications, nutritional deficiencies, GI bleeding, ulcers, hernias. And so some of the things that we're kind of looking at is so there's something called dumping syndrome as well too. So dumping syndrome is where you have an osmotic change, and when they're eating food, they're pulling all their nutrients through, and it's causing diarrhea. It can cause flushing, and a lot of times they kind of have to change how they're kind of eating to modify that. Most of the time, this will get better a few months after their surgery, but there is also late dumping syndrome, which can still happen years out from their surgery as well too. So the other thing we kind of talk about is weight regain. So sometimes these patients have a Roux-en-Y gastric bypass and they start gaining weight back. And that sucks because they had a major surgery to lose weight. And usually people that have had a Roux-en-Y, they've gone through lots and lots of counseling. They've gone through lots of appointments. They've shown that they can do all these things to kind of lose weight. And then the insurance finally, after a long time, approves them to have a Roux-en-Y gastric bypass. They lose weight and now they're gaining weight back. So what may be happening? Sometimes it is they're overeating, but a lot of times there could be something wrong. There could be a gastric fistula, their pouch could be opening up, or they could have a widened gastrojejunostomy. So if you take a look here, this is wide open. So basically food is just going down. It's not getting stuck in the pouch and they're not feeling any early satiety at all. So we'll pull up the next video here. Here. Yeah, yeah. Here or is there another tab? Oh, there. Okay. Okay, here we go. It's loud. That's my preferred way of doing it, the 360-degree. All right. So it's the same suturing device. We're just using it in a different way, targeting where the anastomosis is and basically kind of closing it down. So it's called a purse string suture. So we just go around and we usually take about 12 bites and we close it over a cinch, and we have a balloon that's inside at the same time. That way I don't just close the lumen completely down. And after we close it, the balloon is about 8 millimeters. So there's only 8 millimeters of room. So this is after, so first we burn the edge, and then we go in there and then we suture all around. And then once we close it down, it's about 8 millimeters in width. So this was a study where they basically took a look at these patients that were gaining weight after the Roux-en-Y. They did a tour on them, and afterwards it stopped weight regain, and they went on to lose an additional 10.5 kilograms afterwards. And the number needed to treat was 1 at 6 months, 1.1 at 1 year, and 1.2 at year 2 and 3. So their conclusion was tour stops weight regain, provides weight loss with a low number needed to treat, and patients with weight regain post-bypass should be evaluated for a dilated stoma. So this is the 5-year outcome. They basically found no severe adverse events with TOR, and that it's effective for stopping weight regain after Roux-en-Y with a large gastroduodenostomy. So I always tell the fellows, like, if they're gaining a bunch of weight now after Roux-en-Y, look for a gastric fistula, and then let's see if they have a dilated stoma. It's not just them eating more food. So there may be an anatomical issue that we need to help them out with. So as of July 1st, 2023, there are official hospital codes for ESG and TOR. That's what's so exciting. In the past, it was all cash pay. Now, Medicare is going to start paying for this. So there's hospital codes. You just have to kind of work through the approval process and stuff like that. But I'm really excited about that because this is how all these procedures start, is where you start with, cash pay, then a hospital code, and then eventually the physicians will get their own code as well too. So that's kind of what we're looking at. So takeaways: we've got lots of new endoscopic tools. These do not replace lifestyle dietary changes. Only a small percentage of patients actually get surgery that want surgery. And bariatric endoscopy is just another tool that we can help these patients with. And obesity is growing. I always tell people, even if we do this procedure, you still have to do everything else. This is a tool. This is not a guaranteed, if you look at the study, 80 to 90% of patients lost weight after this procedure. There was 1 out of 10 that did not lose weight. So we really want to select patients very carefully. My ideal patient to do this procedure on is one that has been trying dietary lifestyle interventions for a long time. They've seen the dietitian, they're actively trying to go to the gym. They've probably been fluctuating, gaining weight, losing weight back. They've tried Ozempic, they couldn't tolerate it. They thought about surgery, decided they didn't want to do surgery, or they were kind of not wanting to do surgery. And then this was a way that they want to see me to talk about it, So that's my ideal patient. If there is someone that I've met, and he's a bariatric surgeon in Texas. He does a ton of them. There's like five in this group, and he offers everything. He offers Roux-en-Y, duodenal switch. He offers ESG. He offers balloon, and he gave me some good advice. He's like, when the patient comes, they've already researched. They kind of know what they want, and you basically, as long as medically indicated under guidelines, you kind of give them what they want, because at the end of the day, that's the result that they're going to have to live with. If you try and convince them to do something else and they don't do well, have a complication, that's not going to go well. So the patient has to buy into it as well too. So that's kind of my thought process behind it. I don't want to do this on everybody. I only want to do this on patients that really have failed everything else. And we know on studies that once you start losing weight, that metabolic set point kicks you back down, and then your body wants you to regain weight. And it's unfortunate, but it is just what it is. So we know that this procedure will reset that metabolic set point, and that this can really help them lose weight and prevent all those comorbidities. So, questions? Yeah.
Great review. So, few questions.
Yeah.
But I know everyone has questions. But my first question was those poor lap band patients who went through all that.
The lap band.
Yes.
Yeah.
So
Gotcha.
who didn't ask us first? So
Yeah.
they either had a curve or now, or they
Yeah.
have it in there, but it's not. The port isn't still there.
If it's
How
in
do
the
you deal with those?
So if the lap band is in the right place, we actually shouldn't be communicating with the lap band. So we can still do this. Now, what to do with the lap band? That I don't know.
Okay.
I would defer that to the surgeons that put them
Sure.
in, or to Lizzie. Yeah. So yeah, but they can be yeah. So
Taken out surgically, or can they take that?
yeah. And what's nice about the ESG is that it can be a bridge to definitive surgery like Roux-en-Y. So just correct me if I'm wrong, but basically we do this, the fundus is still there. So these patients can still have a Roux-en-Y gastric bypass. They want to do that. Now, going from an endoscopic sleeve to a vertical sleeve is probably not the best idea, because we cause a lot of scar tissue and it will be hard for them to fire that staple gun. But my understanding is they can get away still with a Roux-en-Y gastric bypass. So maybe you have your
Yeah.
patient who has a BMI over 70. We do an endoscopic sleeve, they lose a bunch of weight, and then they go on to have a Roux-en-Y. So this is something that is us kind of communicating, kind of figuring it out, and trying to do what's best for this patient,
So, and I've seen that a lot because we have a huge program.
Yeah.
So many of the sleeves, some of the sleeves
Yeah.
have been converted to Wi-Fi.
Yeah.
Many times. So my other question was related to you talked about the varices. So are you typically doing a fiber scan and doing endoscopy prior to?
Oh, yeah,
like,
no,
the way,
so,
surgeons
yeah.
do, like screening the liver?
Yeah, you typically don't so that question's been asked, you typically don't have to do that. I think what's nice now is we're not cash pay. So if, so the patient's not paying $20,000 upfront, and then I get in there, I'm like, crap, so now I can go in there and be like, whoa, there are varices, there's PHG, like you can tell endoscopically if someone's got.
So do you do a
So-
previous EGD?
No, we don't typically do that, but now if there is a concern, like maybe the platelets are
Okay.
under 150, they have NASH, they have known NASH.
And how do you know
Then-
they hired?
So you would go in there, you'd see that, and then you'd
Oh,
have to
Okay.
have to
Don't do
abort.
any previous
Yeah.
imaging or-
No, we don't typically do that. And you would abort, you'd have to just
Okay.
stop. Yeah. Yeah. Otherwise, people have asked that, but then you're adding another EGD into the cost of it all, and so that has its own cost as well too. So there's been some nice case studies where people have done EGD and portal pressure measurement with endoscopic sleeve. So we go in there, we do it. So these are patients that have F3 NASH, and they're not sure if they're cirrhotic or not, and they're not sure if they have portal hypertension. So we go in there, we do an EGD, we say, looks good, there's no varices. Then at the same time, I slip an EUS scope. I stick a needle into the middle hepatic vein and a needle into the portal vein. I measure the two differences in pressures. That looks clean, and then I proceed to do the endoscopic sleeve. That's a lot of stuff. So that's not something we want to be doing on everybody. But like if you were to send me somebody and it showed F3 and they had NASH, and we don't know if they were cirrhotic or not, the first thing I would do is I would do an EUS liver biopsy. I would go down there, allows me to do an EGD, look for those varices, and if that looks clean, I can do a 5-minute EUS liver biopsy. I literally just take a piece of the liver, and I do it under ultrasound. And we're doing this a lot now. So what's nice about it is when I do it under EUS, I can do a blood patch, meaning I stick the needle in, and then once I confirm I have nice core, I can pass the stylet back through, and the blood that's in my needle, I pass that back into the liver. And then before I remove the needle, I Doppler the entire time. That way you can't bleed from a liver biopsy if the needle's still in there. So I'll let the needle sit in there for 3 minutes and I won't pull that thing out until the Doppler's negative. So we're doing a lot more liver biopsy now. In the past, we never wanted to do liver biopsy because we've all seen complications from IR liver biopsy, and it sucks. But now with EUS, like if I have a 25-year-old and they have elevated LFTs, I don't hesitate to do a liver biopsy now because it's safe. And if we find out they're F2 right then and there, that's major. That's a major problem. A 25-year-old with F2. And then I've had a lot of patients that everyone thought it was cirrhosis of the liver, and they couldn't tell if it was cardiac or versus liver. We do the biopsy, it's completely clean. And now what they need is a heart transplant. It completely changes the entire paradigm,
So what about
So yeah.
gastroparesis patients are because they can't do GLP-1s?
Yeah.
What do you have to offer them?
Yeah. So okay, so that's an interesting question. I don't think people have really decided what to do there. I think with the gastroparesis, people are more focused on their nausea, vomiting than everything else.
Do balloons like removable balloons or any of
I mean, you probably could, but you're gonna make their gastroparesis a lot worse. Yeah. So it's not yeah, it's not a good idea. So for me personally, when I see gastroparesis, I'm doing a procedure called G-POEM. It's a it's a pyloroplasty from the inside. So that's typically what I'm doing. I'm not offering them a ESG. Yeah. Now there is a procedure that out at Harvard that they're doing. It's called GEMS plus ESG. I think it's a little bit too extreme, but what they're doing is they're doing a antral myotomy plus an ESG, and they're seeing even more weight loss than just ESG alone. So they're tunneling through the stomach, and then they see the muscle of the stomach, and then they're cutting the muscle down. So the bottom of the antrum can't contract, so food will sit there longer, make them feel fuller. I think that's a little bit too extreme.
Yeah.
But it's a new procedure they're looking at, coupled with ESG. But yeah,
So because one of the things with gastroparesis patients gain a lot of weight is
Yeah.
because they prefer liquid diets, which are very high carbohydrates,
Yeah.
calories.
Yeah.
So
Yeah.
All of these patients also need to be on a diet which is more balanced post
Yeah.
procedure. Now you said, does the ghrelin not go up here?
It does
You're
not.
cutting the corner.
Does not. The ghrelin does not go up.
Does
That's
not
correct.
go up.
Does not go up. It does not have that compensatory increase with weight loss. That's correct. Yeah, but if you do look at the hormones and you compare the hormones between laparoscopic sleeve and endoscopic sleeve, laparoscopic sleeve does affect more hormones. So it is
Correct.
more
So what
effective
is the
at the hormone
metabolic
change.
effect in the sense that in terms of resolution of diabetes?
The insulin secretion pattern gets better. That's what we see.
And how many people can go off of it? Like with gastric bypass is the highest, sleeve is close to that.
Yeah.
What about
I honestly don't know the number off the top of my head, but we do see that the metabolic syndrome, their diabetes and the hypertension do get better in the same fashion as the medications and weight loss as well too. So yeah.
And have people used GLP-1s after?
That there's some new abstracts about it, but the GLP-1s are so new. We're going to see more data on that in the next few years. So
a lot of people do use it after.
Yeah.
Sleep surgical.
Yeah, absolutely. Yeah, we don't have any published data about that yet. There's some abstracts, but nothing where we would describe that yet.
Let's see more.
So yeah.
So is there a reason why you don't do this? Is it technically difficult?
No, that's just kind of how everyone's kind of done it. It is technically a little more challenging. You'd have to turn your scope to the left, but usually we don't touch the fundus, and also because of safety. We are grabbing we can potentially grab organs from the outside. So you don't want to be grabbing the diaphragm. So the diaphragm is not something you want to grab. So also, so it's mainly the diaphragm, and also the fundus is very thin. So we don't usually want to be grabbing that area. So typically what we do is we put water and it sits in the fundus, and then we stay away from the fundus. So that's what we typically do. People call it the fundus lake. Just stay away from it, and then just focus on the body and stay away from the antrum. The antrum, you have your gallbladder. So that's why we don't mess around with the antrum either. So one of the big things about this is you do need someone that understands what they're doing, not just the suturing part, because we use a driver. And as soon as your tech is driving in, you need to be pulling and grabbing a full thickness bite of the stomach. So we're doing full thickness. Now, if you're not good at it, you could potentially just catch the superficial mucosa, and then they come back and the whole thing's just like unraveled. So there is a testament to have somebody experienced in doing this procedure as well too. So there is variance in that. So yeah.
Bleeding risk and pancreatitis.
Yeah. So pancreatitis shouldn't be a risk factor. Bleeding, there is always bleeding when you're doing this. Once you deploy the suture, because you're like cinching it and making it tight, it usually stops. So people that do it, we see a lot of bleeding. It usually stops once we deploy the suture. Obviously, you don't want to be doing it if they're on Xarelto or Plavix or something like that. But for non things like that, because we're literally throwing in sutures that stop bleeding, So yeah.
Close the thing and see if there are questions.
Hey, how long does this usually take?
A endoscopic sleeve. So the procedure, 1.5 hours. And as you do more and more, probably 1 hour is what people say. And a tour is 45 minutes. And if you want to learn how to do it, I am happy. Yeah, okay, all right, okay. But if you ever change your mind, I can show you, if you want to learn. Yeah.
Like police. I know there's some people that have a low protein across the board, as many practices you see of these. And there would be no need for it. And I know that they got like more bariatric surgery. So I don't know if there was time, So then after that, whenever I would see something like that, I would look, and I would find they got bariatric.
Gotcha.
Just mention that.
Yeah. So I don't know about sleeves and stuff, but maybe with the previous bariatric surgeries, but I don't know about the sleeves. Yeah.
A couple of questions.
Yeah. Oh, okay. Yeah, so BMI drop. So typically it's about 49% of excess body weight loss and about 40% of your total body weight loss. So obviously the BMI is going to be dependent on how much you weigh at first. And then have you compare to Endo B to okay, yeah. So definitely surgery, you're going to lose more weight. Yeah, if you do surgery, you're going to lose more weight. No doubt about that. So there's no doubt.
49% of the
excess body weight, and then 14% total body weight loss at 1 year, and then at 2 year, 20% body weight loss. And then you may ask, what's more effective, Ozempic versus ESG in terms of cost? In terms of cost,
yeah.
At 3 years, ESG is more cost effective at 3 years.
Can't even get
Yeah, you can't even get it. Yeah, so at 3 years. Yeah. If there's neuroendocrine tumors, we are not doing ESG. So no ESG on neuroendocrine tumors. Yep. Any other questions? What additional information does ultrasound give in comparison without? Oh, the endoscopic ultrasound is just for the liver biopsy part of it. It's for me to see the liver and take a needle and go into the liver. It doesn't add anything to the actual bariatric procedure itself. But it would be nice to know if your patient has cirrhosis or not, So, yeah. Any other questions? Yeah. Yeah. So honestly, it's just a CBC and a CMP and INR. Yeah. Oh, so that stuff. Okay, great question. Okay. We're still trying to figure that out.
Okay.
So everyone's trying to figure that out because it just got approved July 2023, where Medicare has an official hospital code. So the Apollo people have a whole team that's kind of going to help us with approval process. And so it's basically what each insurance tells us they want. So if you look at one procedure, POEM. So POEM is a procedure we've been doing for over 10 years, and it came out as an official procedure listed code, I think in 2021. And every insurance wants something different. All of them want an Eckhart score. Some of them want this in your note, that in their note. Everyone is like different. But at the end of the day, if your team can navigate it, then the poem gets approved as long as it's like achalasia diagnosis. So for this, I think it's going to be a situation where we're probably going to get a few denials, and then they're going to be like, well, we want more dietitian stuff. So hopefully it'll get fine tuned, but really in my mind, I don't want to do it unless they've documented and they've seen a dietitian, they've done lifestyle, and they've seen you guys and been offered medications. And if they want to see a surgeon, I'm sending them your way. You know what I'm saying? That's kind of what we're looking at. And if they're on the fence, I'm all about having multidisciplinary like meeting. Like I want you to have all your options and you decide what you want to do. Like I'm not trying to like sell you and say this is the only way to do it. So yeah, and it's how I approach everything that I do. I do a lot of procedures where I'm removing early stage tumors and stuff. And the last thing I want to do is just say, oh, you're cured, you know. So I like to make sure oncology, everyone's on board. We're all on the same agreement that there's nothing further that needs to be done. So yeah.
Just recently with the GLP-1,
Yeah.
there was some internationally, some suicide sort of things. And so any weight loss item. Yeah, because any weight loss agent, whether it's surgery or procedure or medication, I think that patients with severe depression, you need to counsel them and maybe have their psychic mental health. In fact, alcoholism increases. In fact, that's why one of the earlier medications, Ramonabant, was FDA didn't approve because of high endocrinology. So I think getting endocrinology, yeah, cannabinoid. It was in the certainly having a behavioral health.
Absolutely. So yeah, I mean, my vision is hopefully we have all of these things in one clinic and that these patients get what they need and we continue to follow them, make sure our outcomes are really good. That's what's important. It's not just doing the procedure, you know, making sure our patients really get that weight loss and they're taken care of, you know. So yeah. Any other questions at all? Cool. All right. Thanks for having me.